going to be presenting a prosthetic case study. I am currently rotating at Hanger in West Covina, and I didn't see this patient for the initial eval, but I was there for 2 of the follow-up appointments, and I got to work on her leg for a little bit, so I decided to talk about her during this case study. So here's a quick overview of all the topics that I'm going to be covering during this presentation. So let's get started with the patient history and demographics. She is a 50-year-old female who's 5'4" and 172 pounds. She doesn't have any known allergies, and she's currently not taking any medication. She also has no comorbidities. Her amputation is of the right limb above the knee, and it was caused by a motor vehicle accident when she fell out of a bus in 1986. And the ICD-10 code related to her diagnosis is Z89.611, which stands for acquired absence of the right leg above the knee. Quickly about this pathology, according to the Amputee Coalition, there are about 185,000 amputations that happen each year in the U.S., and out of that number, 45% of them are caused by a traumatic event. For example, a car collision or an accident with machinery at work, or an accident at home with like a lawnmower, or an electrical accident. And this accounts for about 83,250 amputations each year. Out of that number, 70% of those are upper limb amputations, and about 30% are lower limb. This is due to the fact that usually if you're working with machinery, you're using your hands or your upper limbs, and or when you're driving, you have your arms stretched out, so that's why there's a larger percent of upper limb amputations that are directly related to trauma. So that's some facts about that kind of pathology. We're going to go back into the patient eval. Starting with the subjective information. She currently stands about 60% of the day, or stands or walks about 60% of the day. Although she's currently retired, she's a full-time stay-at-home mom of 2 teenagers, aged 15 and 17. And so she's involved with all their sports and social events, having to drive them there, climbing up the bleachers during the games, and also cooking and cleaning. Some additional avocational needs include gardening, shopping, and camping with her family about 3 to 4 times a year. Her last prosthetic was given to her in 2009, and it's now giving her issues, mainly due to the age and of the prosthetic, as well as the wear and tear of the components. And she also gained 31 pounds since that last prosthetic was given to her, so it's causing her issues with the fitting. For example, she currently has no ischial containment, as her limb kind of sits out of the socket due to her weight increase, and this makes her feel insecure in the ML plane, because when she's ambulating, she doesn't have that bony lock, and this is also causing gait deviations because the suction suspension she has on there is not currently working. Also, her knee is pretty old. It's buckling because of the decreased flexion resistance function of the knee, and it had been sent out to Ottobock for repairs, but they returned it saying that it should be replaced due to the wear and the malfunctioning of it, so they don't want to have any risk of falling or anything with that knee, so it should be replaced. The foot is also in a similar condition. It's not keeping up with all of her activities. As I mentioned before, she's pretty actively involved with her kids and with their sports events, etc., and it has a potential to malfunction due to the wear. So her goals, as she expressed, were to ambulate efficiently and without a cane, because currently she has to use that as an extra stability measure. A better fitting socket that's comfortable, that doesn't press in uncomfortable areas, and a device that can keep up with her ADLs, as she currently feels like she cannot keep up with all of her activities, and she kind of has to slow down because of the malfunctioning of all the components and the ill-fitting socket. So moving on to the objective patient eval, it revealed that her upper limbs are not involved. They're functioning within, they're working within functional limits. The consistency of her limb is soft, and yet she doesn't have any contractures at the hip. And her left leg, the sound side limb, is completely intact. It's 5 out of 5 for all the minor muscle testing with no contractures at the knee or the ankle. And her residual limb is only slightly weaker, with 4 out of 5 minor muscle testing for flexion and extension, as well as internal external rotation and adduction abduction. Like I mentioned, her consistency is pretty soft, but she has really good skin condition with great coloring and intact blood flow, and she doesn't have any major scarring, no invaginations, and based on all the previous ADLs I mentioned, she is considered a K3 ambulator with a K-PAVIT score of 67. So moving on to treatment plan and formulation implementation. The socket design that my clinician decided to go with was an ischial containment socket. This is due to the fact that ischial containment will get all that residual limb soft tissue that's redundant into the socket and contain it that way, as well as decrease discomfort and increase the ML stability due to the bony lock that it has with the ischium and the bones in her leg and her pelvis. The socket also has total contact skin fit suction suspension design. This is to increase the control of her prosthetic, improve the suspension, which she currently doesn't have, as well as increase the proprioception, so she's able to control her prosthetic a little bit better. There's a Proflex inner socket with a rigid laminated frame, and this is to increase comfort as well as decrease skin abrasion and accommodate her anatomy. As you can see in the picture, the darker carbon fiber is kind of what gives stability, but the soft, flexible Proflex is kind of what gives the comfort of the prosthetic. And there's also a rotation unit in the alignable components. This is to decrease skin shear and absorb excess rotational forces as she ambulates. And then moving on to the knee and lower components, she was given a C-Leg 4 microprocessor control knee, which helps with knee stability. It can reduce energy consumption, as well as keep up with her varying cadence as she negotiates stairs and ramps at the bleachers for kids games, etc. It also has swing and stance-based control, so it can help her complete her ADLs more efficiently. And although she has not fallen yet, we want to prevent falls and potential additional injuries with the stance recovery function of this knee. The stumble recovery function of the knee, not the stance recovery. Also, the clinician indicated ultralight materials for her to reduce the weight of the prosthetic device, and this will increase efficiency as she ambulates, obviously, and also increase the durability of all the components. And finally, for the foot, a FlexWalk's foot is indicated for her because it will decrease compensatory movement, also allow her to walk on uneven surfaces, and this is to help her when she gardens so that she feels secure while walking on uneven grass or gravel. And I think actually the foot that they gave her was an Ottobock, I think it was an 1C3 foot, which adds additional stability for when she goes camping with her family. So moving on to problem solving, there's a few of the issues that came up while working on this prosthetic leg. During the first check socket had a lot of proximal lateral gapping, kind of in that trochanter area. This was an easy fix by remodifying the socket and having her come back for a second diagnostic socket. Insurance usually pays for up to 2 check sockets, so it was completely under normal care, as well as the suction suspension valve was leaking in her finished leg. It was leaking air, which means that she would lose suspension if she tried wearing that leg, so this was also a quick fix by sealing the outer valve to make sure it was airtight and no air would come in as she was walking. During the follow-up appointment after the finished prosthetic was delivered, there was a few areas of discomfort, including the ischial seat. So this was taken care of by trimming down the rigid shell, which wouldn't compromise stability or suspension, but it would definitely increased comfort. And the ramus ankle was also causing excessive upper pressure. So same thing, the clinician just trimmed down the rigid shell and flared out the flexible inner socket a little bit more so that it wouldn't be pressing up as much. And again, with these small modifications, the stability and the suspension of the prosthetic was not compromised at all, but it definitely increased comfort, as well as increasing the amount of time that she can wear this leg for. And that was pretty much all that I was able to observe, and I have not seen her back at the office yet, so which probably means that she's doing really well with her prosthetic. And yeah, that's pretty much the presentation. Here are my references that I used for this presentation. Two of them are just statistics on amputations, and the third one is Lasardi, which has a lot of information about the components indicated for K3 ambulators. And that's it. Thank you very much.